So I think you've heard from the first two speakers how important lifestyle is, as well as family history, which probably impacts how one might think about screening. And so screening for prostate cancer is a very controversial issue. Our next speaker, Dr. Jonathan Wright, is a urologist, a surgeon, who treats prostate cancer, and he has a lot of interest and expertise in screening, and he'll be telling us about that now. Jonathan?
Thank you, Pete. Thank you for giving me a controversial topic to discuss. So, prostate cancer screening does have a lot about it, and certainly it calls on PSA and the role of PSA, and all of us in this room, I'm sure, have seen the tremendous amount in the press about the role of PSA testing and what the government has come down and said whether or not we should use PSA testing. So I'm not going to have an extensive debate over the pros and cons of PSA testing. I'm going to assume for this audience that there is a role for PSA testing. We certainly do believe that there is a role for PSA testing, but we need to use it judiciously and appropriately in our clinics. And so I'm going to talk today, review a few of the issues about PSA screening, discuss ways that we can improve PSA screening, and tell you what new or future screening tests may be coming down the pike. So this has been kind of alluded to. This just shows the top cancers in men and the top cancer deaths in men. And so over here, these are the most common cancers diagnosed every year. Prostate cancer is number one, almost 200,000 diagnoses a year in the United States. It's the second most common cancer death in the United States, with 27,000 men dying of prostate cancer per year. But certainly as we're moving toward how we can do better screening, we really want to be making sure we are capturing these patients in our screening. There's certainly a significant number of patients that are diagnosed with prostate cancer, low-risk prostate cancer. You're going to hear a lot more about active surveillance later on, who likely don't need to be treated and didn't need to be diagnosed. And as we heard, there is a certain burden of having the diagnosis of cancer applied to you that is difficult to measure. But if you don't need to be diagnosed with prostate cancer, we probably shouldn't be diagnosing you with it and making you carry that burden. This slide shows cancer-specific mortality in the United States over several decades. So these are various decades from the 30s all the way up to early in the 2000s. And these are the rates of death due to different cancers per 100,000 men. And you can see here's prostate cancer. And you can see there was a significant decline in the rate of prostate cancer death. And this coincided about the time that PSA was introduced. Now certainly our treatments have gotten better, and that has made an impact as well. But I think we have little doubt that PSA screening certainly was an important player in this, to diagnose it early when there's a chance for cure. But despite this, the U.S. Preventive Task Force came down and gave it a grade D that we should not use PSA-based screening for prostate cancer. Now, what is PSA? I tell patients this. It's prostate-specific antigen. It is not prostate cancer-specific antigen. And so there are several things that make every prostate makes PSA. So every man is going to have some PSA running around. So there really is no absolute level of PSA below which I can say you don't have prostate cancer. All men are going to have some PSA running around. But we do know that as the PSA goes up, there is an increased probability that you have prostate cancer. But the issues, and these are things that we as clinicians have to deal with, is that there is a concern and there is a reality of overdiagnosis and overtreatment, and our treatments are not benign. What we want to do is be able to identify those in two groups. One, those that are least likely to die of prostate cancer, least likely to have morbidity from prostate cancer diagnoses, and not screen them. We want to identify those who are at the highest risk of symptoms or death from prostate cancer, screen those patients, and treat them. So one of the challenges that we had is determining someone's life expectancy. And this is difficult, but there's certainly, as we all know, there's a distinct difference between your chronological age and your biological age. Not every 75-year-old man, for example, is equal. So what this shows is the life expectancy based on how healthy you are for different age groups. Let's start with age 75. The average life expectancy for someone in their average health who's 75 is 10 years. And that's where basically where some of the earlier recommendations said, don't screen men who are 75 or older because they're unlikely to live 10 years and thus they're unlikely to die of prostate cancer even if you found it. But those that are in the healthiest quartile, the top 25 healthiest percent of 75-year-olds are going to live 15 years. And even the healthiest 80-year-old is going to live over 10 years. But the 75-year-old who's not very healthy is unlikely to live 5 years and certainly isn't going to benefit from us doing PSA testing. Well, how do we do with this? This was just published earlier this year. This looks at how much PSA testing we as clinicians do in people who are over the age of 75. And all these different bars show the percentage of men that are getting PSA screening. And it's about 40%. So 40% of men that are over the age of 75 are getting PSA screening. What's worrisome, though, is this 75% is those that have the greatest likelihood of dying in 10 years based on their health. So they're very unlikely to live another 10 years, and yet we're still screening over 30% of those men. We need to do a better job about that. Dr. Stanford alluded to this, is that family history is very important, and we are continuing to unlock some of the clues that we can use to better target PSA, better target screening for patients. She showed these numbers. 40% of prostate cancer due to genetics. Father or brother, 2.5-fold increased risk. And if you have 2 relatives with prostate cancer, it's a 5-fold increased risk. That's just basically you're just asking, does your family have prostate cancer or not? That's not getting into the detailed genetics that she's talking about that we hopefully will be able to apply someday for screening populations as well. Race is very important. African Americans develop earlier disease and more aggressive disease. And we need to do a better job of getting these men into our clinics for screening. How can we use PSA better? Well, here are 3 different ways that we can do it better. One is to look at your baseline PSA. And there's some exciting data I'm going to show you that have been coming out about the utility of what your baseline PSA is. What to do when you have a sudden change in your PSA. We see this all the time in clinic, and I'll talk a little bit about that. And then talk a little bit about obesity, too, and how that affects PSAs. So there's a group of men from Sweden. They had over 20,000 men that they collected blood on in the early 80s. And they stored this blood. And then they linked with Cancer Registry in this area and looked at mortality due to prostate cancer and metastatic prostate cancer. And basically nobody got PSA screening in this area. These curves show the risk of developing metastatic and fatal disease based on what your PSA was when you were in your early 50s. So PSA in your early 50s, no PSA screening, 25 years later, what's the likelihood that man dies of prostate cancer? Well, as it turns out, the median PSA for a man in his early 50s is less than 1. The median PSA for a man in his early 50s is less than 1. These 2 bottom curves have about a 1% probability of developing metastatic disease in 25 years. Those men had a PSA of less than 1. These men had a PSA of greater than 1, and these men had a PSA, when they were 50, of greater than 2.5. Single PSA at age 50, greater than 2.5, 12% risk of dying of prostate cancer in 25 years. So potentially we can use a baseline PSA to then say, if your PSA is 0.4, we don't need to get your PSA every single year. If your PSA is 2.6, we better follow you pretty closely. And we are doing models to try to look at this and what the effects might be of doing these different PSA screening strategies. This is Dr. Rutazioni, Dr. Gore, and Dr. Gulati looking at different protocols. What's the age that you screen? What is the frequency? How many years in between PSAs? And what's your threshold for biopsy? The nuances aren't important. But what we're looking at is our people here are trying to figure out what are the probabilities of finding cancer, overdiagnosis, what's the probabilities of missing cancer, to see if we can, again, use what we have to better screen patients with PSAs. Guy comes into my clinic, he's had a PSA of 1.2, 1.5 for years, all of a sudden it jumps to 4.5, referred for biopsy. I don't biopsy him, I repeat the PSA. A lot of these men I'll repeat, it comes back to 1.5. We just saved that man a biopsy and the risk of biopsy and maybe finding a very small cancer that doesn't need to be found. But if I repeat it and it's still 4.5, then yes, there's been a change. We need to look at that. A very simple way to reduce the number of PSAs, reduce the number of biopsies and the number of diagnoses that we find. Obesity. We heard all about obesity this morning. Obese men have lower PSAs. It's diluted out essentially. Obese men have lower PSAs. It's difficult to feel the prostate in an obese man. It's just difficult to get all the way in there to feel the entire prostate. As a result, we're not very good at finding nodules in obese men. Thus, they can have the disease grow bigger before we can even feel it. They also have larger prostates for some reason. Obese men, bigger prostates. You're trying to find a marble-sized cancer. It's easier to find it in a lime-sized organ than in a grapefruit-sized organ. So it's more difficult to find that little cancer in the obese men. And it appears that obese men have more aggressive prostate cancer. So all of these things we need to apply and think about when we're in the clinic seeing a man who's obese, and 40% of our population is obese. We've also done work here showing that some of the medications that obese men take, or all of us take, statins for high cholesterol, NSAIDs for osteoarthritis, both those medications lower PSA levels. Things we need to think about to do better screening. What's coming new? This is the Prostate Health Index, or the PHI. It is available now. It's a blood test. It uses different forms of PSA. Pro PSA, the free PSA, and the square root of the total PSA, and thankfully it does the math for us. We don't have to actually do any of this, but it is associated with prostate cancer risk. It may be more specific than PSA for detecting it, and what's exciting is it may be better for detecting high-grade prostate cancer. It's available now. We need larger studies. We need better science on it, but this is exciting for something we may be able to use, which is an extrapolation of PSA testing. There are also urine-based tests, the PCA3. We do an aggressive prostate massage. We express things out of the prostate, and then we collect your urine, and then we can look at the mRNA in the urine for different factors. This is PCA3, prostate cancer antigen 3. This is prostate cancer antigen, not the prostate-specific antigen. This is prostate cancer antigen. And this appears to outperform PSA, especially right now we're using in men that have had a negative biopsy, and we're trying to follow them up and figure out should they have a biopsy or not. It doesn't change with your size of your prostate. It doesn't change with prostate inflammation. PSA does change in both of those situations. So this is an exciting test. But it doesn't appear to be associated with aggressiveness of prostate cancer. In this issue, what they give you a score. The higher the score, the greater the probability of having cancer, and something we're using. Tempus 2-erg. Dr. Nelson was intimately involved in the early work with Tempus 2-erg, and we're doing a lot of work here with Tempus 2-erg in the clinics, in the research as well. You'll hear more about it later on. It's a fusion of two pieces of DNA coming together incorrectly, and it's detected in prostate cancer. We can also detect this in the urine of men. And some of the work we've been doing with active surveillance, you'll hear about Dr. Lin talking about later, a recent publication looking at urine levels of this genetic fusion that you see in the urine and outcomes of men with active surveillance. We're trying to see if we can use this in combination with PCA3 to better detect men with prostate cancer. So PSA screening isn't for everyone. We can't go out there and just blanket every single person and PSA test it. We need to make it more focused, and that will help all of us. We need to do a better job as clinicians of assessing how long people are going to live, and that's a tough thing to do. We need better tools to do that, and we need to have frank discussions with our patients about this and say, you're more likely to die through obesity than you are of any prostate cancer. Get out there and walk 30 minutes this afternoon. Age is not an absolute cutoff for PSA screening. Chronological age is not biological age. We should screen out the PSAs based on what your initial PSA is, continue to look for new tests. And one thing that I do a lot now in clinic is use these smartphone-based calculators, because it allows the patient to have numbers for what's my risk of cancer. This is just one of them that's available. I got a Caucasian male, 65 years old, PSA of 4.5. He's got a family history of prostate cancer. His rectal exam is normal. He's never had a biopsy. His probability of having prostate cancer is 44%. But his probability of having aggressive prostate cancer is less than 10%. So when you have these data, I've had a lot of patients say, I'll see you back in a year with another PSA, or I'll see you back in 6 months, or I want that biopsy. But it's these kind of things, separating out the aggressive from the non-aggressive, And then you'll hear more on active surveillance later on. The non-aggressive, how do we safely follow them? There's a lot of exciting things coming out. There's a lot of work to be done. We're going to continue to do it. And thanks for being here and supporting it as well.
Thank you, Dr. Wright. So I'll put a plug in here.